Well, myself as a pediatric neurologist, I've always been very interested in diseases of neural connectivity, which include, of course, diseases such as pediatric TM, where the demyelination leads to loss of synapses. I'm also an associate director of an epilepsy unit, and so epilepsy is also a disease of neural connectivity, and I'm also very interested as well in the disease of autism. So today, what we'll do in my lecture is Frank has already talked about what pediatric transverse myelitis is. We'll look briefly at the Dufresne study just to go over a little bit of difference from Frank's data as opposed to the Dufresne data, but it's basically about the same. And then we're going to try to contrast that with the clinical characteristics of pediatric ADEM. And then finally, we're going to try to look at the clinical characteristics of pediatric CIDP, or essentially chronic Guillain-Barré in children. And then how can we distinguish pediatric TM from CIDP? And then finally, I want to talk a little bit about some of the things I'm interested in the laboratory, and this particularly relates to the question of why does a particular child develop a demyelinating disease. And we're going to talk about genomics, in particular a technique from computational biology that might help us answer the question of why a particular child, or why does as a particular adult, we all get viral infections and other things like that. Why did certain patients end up getting transverse myelitis or other neuroautoimmune disease? Okay. All right. So one of the studies that was put out by the French pediatric neurologist in 2004 looked at how frequent are CNS Demyelinating events in children. And they excluded several different types of diseases, but basically we're looking at primary CNS demyelination. And these patients were followed for a period of approximately 3 years, and there was almost 300 patients, but as you would expect, most of them are European. The age of onset basically was almost about 10 years of age, but it did factor out in terms of what the final diagnosis was. Patients who develop pediatric MS typically presented about 12 years of age, so they tend to be the oldest. Monophasic ADEM will present at about 7 years of age, and patients with a single focal episodic demyelinating events, such as transverse myelitis, tend to present at about 9 years of age. Infections were much more prevalent in patients who either had ADEM or a focal episode of demyelinization versus those that finally had pediatric MS. TM was higher in those with a single episode as opposed to being very, very low in MS or ADEM. And as one would expect, optic neuritis was much more common in patients with multiple sclerosis as opposed to ADEM. Brainstem dysfunction was a little bit more common in ADEM, and that sort of goes along with the fact that ADEM tends to present acutely with an encephalopathy, i.e. the severe mental status changes are much more common in kids who have pediatric ADEM as opposed to multiple sclerosis. The initial MRI findings are very predictive in many cases. Those in the group who had a final diagnosis of pediatric ADEM, if the initial diagnosis was suggestive of ADEM, then 100% of those patients ended up with a final diagnosis of ADEM. In the group with the final diagnosis of pediatric MS, 57% of those patients were suggestive of pediatric MS on the initial MRI, and none of those looked like pediatric ADEM. And we'll talk about those MRI findings in just a few minutes. The distribution of the lesions on the MRI are fairly characteristic. Subtentorial lesions were about the same, but thalamic or basal ganglia lesions were much more prevalent in children who have pediatric ADEM. Optic neuritis, as you would expect, was more prevalent in kids with MS. Spinal cord lesions were also prominent more in the pediatric MS group than versus ADM. Tumor-like lesions that look like an astrocytoma on the MRI were a little bit more prevalent in patients who had ADM. And then, of course, patients who had gadolinium enhancement were much more likely to have pediatric MS as a final diagnosis. The CSF findings, there tends to be more of a pleocytosis in ADEM versus pediatric MS. The protein's a little higher in ADEM versus pediatric multiple sclerosis. But importantly, and this is the reason why that acutely we send oligoclonal bands on all of our patients who present with a single demyelinating event. Oligoclonal bands are positive in about 40% of patients who have pediatric MS, and that's very helpful in terms of us predicting for the families whether a patient might be at risk for going on to develop pediatric MS. So the predictive factors of a second attack of demyelination: age of onset. The older age of onset, you were more likely to develop a second episode of demyelination. Presence of myelitis or optic nerve lesions increase the risk. An MRI, of course, suggestive of pediatric MS. And then finally, those that protective factors or factors that suggested that you wouldn't have a second attack, the MRI at the onset suggestive of ADEM, which is for the most part a monophasic event. So we've heard from Frank about the Johns Hopkins data. Let's talk about the Dufresne study real quickly. This is the other modern study that's been published in the last 20-some-odd years. It came in the Journal of Child Neurology and only had 24 patients. Again, defined as bilateral onset of acute onset, of bilateral spinal cord dysfunction. The mean age of onset was about 8 years of age, and the male to female ratio is about 1 to 1. 50% of the cases happened in the winter season. About 60% of the patients had a viral URI of some sort. And fever was present actually in these cases in about 60% of the patients at acute onset. And then in the initial phase, the first 5 days that the symptoms were present, a severe symmetric pain, which is really very characteristic of children who have pediatric TM, was present in about 88% of the patients who had TM over one or more spinal segments. And the younger you are, the more that you tend to have pain in general. The younger patients especially can have some neck pain, suggestive that they actually have meningitic involvement or inflammation of the meninges. Most of these patients had sudden or severe motor dysfunction over 12 hours and respiratory insufficiency in about 30% of the patients. But the mean duration of going to the plateau phase or the nadir of your symptoms was about 6 days. As I said, pain was very common, and it was most common in the neck. And 23 of the 24 patients had a symmetric flaccid paralysis of the lower extremities with sphincter dysfunction. DTRs were mostly suppressed, and about 40% of the patients had a moderate upper extremity weakness as well. Sensations were abnormal in approximately 80% of the patients, and most of the time it was asymmetric, and sphincter dysfunction was very common as well. All these kids were treated with IV solumedrol. And reminder, this is in France over about 10 years or so. The mean duration of follow-up for reporting this data was about 7 years. And the mean time to independent walking was about 16 days. And this looks very similar, the recovery data, to what the Johns Hopkins data says, with about 50% having a normal outcome or 13% having mild motor sequelae, and then about 40% having moderate to severe and motor sequelae. So the outcome factor, This is the one thing that Frank said was different in their data, and that was the unfavorable outcome. The complete paraplegia or time to maximum deficit less than 24 hours in this particular study was associated with a more unfavorable outcome. The favorable outcomes was associated with getting to a nadir less than 8 days, and then a time to independent walking of less than 30 days. And no patients had a recurrence of their TM or other neurologic deficits. In this study, there were no patients that developed multiple sclerosis. Abnormalities, there was actually, in this study, there was a mean number of 210 cells in the CSF, and only 3 of the 24 had slightly elevated protein. I tend to see that to be a little bit more elevated in 40% of my patients that I've seen. And in 20% of the patients had some sort of evidence of some sort of viral infections as detected by serology. None of the kids in this particular study had oligoclonal bands, as you would expect with pediatric TM. And the MRIs, for the most part, had swollen and increased T2 signal really over most of the core, both through the cervical and to the thoracic region. Now, let's contrast that with acute disseminated encephalomyelitis. And this has been gone over before, but I'll just reinforce it. This is an inflammatory disease that strikes younger children. A typical age of onset is about 5 years of age, and it's a monophasic illness in 90% plus of patients. And there's some sort of infectious event or vaccination that occurs about 1 to 4 weeks prior to the onset of neurologic symptoms in about 75% of the patients. And the typical prodrome before this is about 12 to 14 days for most kids. The Tenenbaum data from Argentina, again, there was a significant prodrome in about 35% of the patients. GI and varicella, if you add those two together, it's roughly somewhere around 50% or so. Kids tend to present with a couple of different things, one of which is a change in sensorium. The second one is that they tend to present with some sort of cortical spinal tract signs, usually in acute hemiparesis. And the third thing that you commonly see is something called a cerebellar ataxia. They have a real inability to be able to walk in some way in most of the cases. And about 35% of the kids will have some sort of seizures. So a very different presentation from pediatric MS or pediatric TM. And they can have optic neuritis, although it's much less common. Now, the radiologic features are really in 4 groups. Group 1 is most common, where you have these scattered small lesions of T2 hyperintensities that are in the gray and the white matter. And it's very characteristic of children who have transverse ADEM. And a lot of times you can see that in combination with those in group C, and that is that you could have bilateral symmetric basal ganglia or thalamic lesions as well. Less common, you can see this confluent or tumor-like mass that looks like an astrocytoma or a large demyelinating lesion that has a hemorrhage in it. These kids they do have a pleocytosis, but you don't necessarily need to see that. And their protein is elevated, but you don't necessarily need to see that. But very importantly, just like all the other patients who do not have pediatric MS, 96% of all these kids don't have any oligoclonal bands. Now, what's the treatment that we typically give? Well, the treatment, of course, is solumedrol or steroids, and we give 20 mg per kilo per day for 4 to 5 days, followed by a taper. Kids in the Tenenbaum study got a variety of other drugs, including anticonvulsants, including treatment for herpes. The the fact that about 16% of them were actually ventilated, that's a little high. I mean, normally you see only about 10% of your patients will be ventilated who have pediatric ADEM. And we talked about the steroid taper. If you look at the mean follow-up time of 6 years that was in the Tenenbaum study, those that had either scattered lesions on their MRI or they had those types of lesions plus lesions in the basal ganglia, nearly between 80 to 96% of those patients ended up having a normal outcome. Those patients who had blood and with their demyelinating lesion have a much less favorable outcome. The residual deficits actually from pediatric ADEM are actually relatively low, but if you do have it, it tends to be more. It tends to be a little bit more on the severe side. Hemiparesis in about 8%. These symptomatic partial epilepsies these kids get tend to be refractory to medications. The visual acuity reduction and the mental handicap are the two other things that could be are not that common, but they can be pretty significant in these patients. Now, biphasic and multiphasic ADEM. The question is, where does this end and pediatric MS begins? Typically, kids with multiphasic ADEM will present maybe at a slightly younger age, and they'll have like 1 to 2 relapses. The mean time, but they tend to have their relapses, 3 to 4 years apart, which really distinguishes these guys from kids who have MS or other things like that. These kids don't have oligoclonal bands in general, and if you look at the patients that have been reported with a mean follow-up of 8 years, most of them tend to do pretty well overall. Now, pediatric chronic Guillain-Barré or chronic inflammatory demyelinating polyneuropathy is slightly different in terms of its presentation. You have a subacute onset of a progressive, more proximal than it is distal weakness over at least 2 months or so. Research criteria is listed there. The series that have been reported is about 1-to-1 male to female with age of onset about 11 years of age. In general, for the most part, in a lot of centers I've been in, the ratio of female to male has actually been about 2-to-1, so it's a little different from my experience. There are 2 groups that present. One is a progressive loss of ambulation over 1 to 3 months. They tend to be very, very responsive to treatment, but only a minor number of them can have only a monophasic course. And 30% of them actually can look like Guillain-Barré, but it's over a much more prolonged presentation, i.e. about 1 to 4 weeks. But it's proximal weakness versus Guillain-Barré, which is distal weakness. And we talked about the relapsing course already. They tend to have about 4 or 5 episodes, and each of those episodes tend to respond fairly well to treatment. They can have fatigue and sensory symptoms. Large fiber sensory loss is really much more common, so they tend to have more problems with balance than they will with small fiber problems such as pain. And a very, very small minority of those patients will need to be ventilated at any point in time. CIDP has a very, very uniform electrophysiologic characteristic with non-uniform slowing with conduction block. Transverse myelitis, of course, could mimic CIDP, but transverse myelitis, of course, has a much more acute onset, and it has both distal as well as proximal weakness. Hereditary motor sensory neuropathies are usually more distal in terms of their motor loss, and the sensory loss tends to be a little bit more severe. And of course, oftentimes with hereditary motor sensory neuropathies, there's a dominant inheritance, so many people will have a family history of that. An acquired myopathy can look like CIDP. CIDP, of course, has proximal weakness, and so does acquired myopathies. But the most common acquired myopathy for children actually is dermatomyositis. And you've got this very, very dramatic red rash in addition to an inflammation of muscles. So, and the CK, or the creatine kinase, is extremely elevated with acquired myopathies. There are occasional autosomal recessive neuropathies that present, such as metachromatic leukodystrophy or Krabbe's disease, which is a neurodegenerative disease. Sometimes the peripheral nervous system disease can precede the onset of dementia in these children, but the MRI in these situations can be helpful. The treatment, this is a humoral immune disease, so they oftentimes will have a humoral immune response. They'll have elevated intrathecal IgG synthesis. They oftentimes will have antibodies against components of myelin. They almost always respond to steroids, IVIG, or plasma exchange. And their prognosis is really pretty good. If you look at short-term studies, 12 to 60 months off of therapy, most of the kids have little or no disability, although we really don't know what the long-term prognosis of this disease is. But it's said by the old-timers to be very excellent. Okay, so we have, over the years in our laboratory, we've been interested in the genetics of axon guidance. And there has been a very powerful computational biology technique that's come to the forefront over the last few years and really help us address why did my child develop some sort of demyelinating disease. And it's using this program called WebQTL. It was developed by Robert Williams and Alyssa Chesler at the University of Tennessee. And the web address is genenetworks.org. And what this is this is essentially a program and a genomic technique that can help us distinguish the types of types of variations in our DNA. We all have variations in our DNA that each make us the individuals of who we are. And this particular program and this particular technique can help us to look at those individual variations to see if you are at risk or your child was at risk for having some sort of demyelinating disease. And I just want to sort of illustrate that with an illustration. The nice thing about this technique is that it's accessible to everybody. It's a public database that's been built by the NIH, and it's very, very easy to do, very program-friendly, or user-friendly. And so it should help us with answering the question of molecular diagnostics. Most of the folks who are in this room, the kids in my clinic, they want to know if they can walk again someday. And and the genetic makeup that we all have can help us to understand how that stem cell therapies can help us try to, using different types of stem cell therapies, help us to try to integrate those cells into the spinal cord or into the brain or wherever we need to have them in a correct way. So the concept of genetical genomics is a combination of trying to look at genetic linkage, which is a technique in which you ask, where in the places in my DNA is it associated with me developing, say, pediatric TM? And also, it's linked with these studies called microarray studies. These are unbiased gene expression studies in which these studies ask, what is the activity of my genes that I have in a particular tissue? Now, genetical genomics, what it does is it treats the activity of the gene, the so-called gene expression, within a population of individuals or within an individual itself as a quantitative trait. Now, what is a quantitative trait? Well, quantitative trait are these locations in our DNA in which there are specific differences or differences in the code of our DNA that are really the foundation of who we are as individuals. Now, what has been developed has been this genetic reference panel. The genetic reference panel is actually meant to model in the laboratory the actual heterogeneity of the DNA that occurs in human populations. And what this model is it's a independent cross of two different types of mice strains. I don't think it's important for you to know the mice strains so much as to know that the advantage of these mice strains is that you have 80 different strains that have been generated, and these strains all have been sequenced, and the sequence differences and the positions of the sequence differences is known in about 1.8 million SNPs, or 1.8 million different locations, as well as 756 microsatellite markers. Now, those are all meant to be places in the genome where that you can actually assign a genetic expression to that may code for a genetic modifier that may actually contribute to you developing, say, pediatric TM. Now, why would we want to map such a place in the genome within a genetic reference population? Well, the mapping, this place is called a QTL, and the mapping of QTLs is really a typical approach for identifying these natural differences in the DNA, okay? And so what you can do is at these QTLs, or markers of known genetic location, you can actually look at the statistical values of, say, having pediatric TM at that particular place in a segregating population. And simply put, at the QTL, the genetic location is very predictive of you, say, having pediatric TM, okay? Away from that place in the genome, the genotype is not predictive of you having, say, pediatric TM. Now, what I've done here is I've done a small little experiment using the program, using as a pseudo marker for pediatric TM the expression of myelin basic protein in the and this is in the hippocampus. What's on the left, what's on the y-axis here on the left is something that's called the LOD score. Okay, that's the statistical association of the likelihood that the expression of myelin basic protein, or you can think about it, the expression of pediatric TM, is associated with a place on that blue line. Okay, and the blue line is the LOD score. If the blue line gets up to that gray line there, that's a very highly statistically significant, almost the p-value at that particular place really goes to infinity. And so what's presented here is the QTL that's on chromosome number 2. You can see there's actually 2 places on the physical chromosome there, and the physical map of the chromosome is in megabases. You can see there are 2 places there where it crosses that significance lines. Now, underneath these, what's so important about these peaks? Well, underneath these peaks are actual genes, okay? And these actual genes have something to do with controlling the expression of myelin basic protein, that we're using this as a sort of a pseudo marker for pediatric TM. You also find QTLs in these mouse population on chromosome 11 and on chromosome 16 for myelin basic protein, okay? And each of these peaks that have these LOD scores here, underneath these peaks that are in the yellow there are specific places where that there are genes that might actually code for the expression of myelin basic protein. Now, if you look at those places in the genome and actually look at the genes are actually very interesting. And you can do the same thing, and the data is actually available for, say, hematopoietic stem cells and other different tissues as well. The chromosome 2 QTL has adenosine deaminase, and chromosome 11 has this polyribonucleotide nucleotidyl Now, what are those 2 genes? Well, those are 2 genes that are actually very important in immune function, the dysfunction of which causes immune disease. Some of these other genes that are listed here, PIT1 and SMEC2, are actually genes that are involved in neural development. And of course, myelin basic protein is a neurodevelopmental protein, so it makes sense that they would be in those places in the genome where it might control the expression of myelin basic protein. Now, this is where the rubber meets the road. Okay, so we mapped some QTLs for myelin basic protein. Okay, as a marker of pediatric TM to different places on the mouse chromosomes. Okay, now this is all of the mouse chromosomes lined up in what's called an ideogram. Okay, and what's noted here in the green and in the red are actual QTLs, or places in the genome where that experimental, the EIE model has actually been noted to have a genetic modifier in that particular place in the chromosome. And as you can see, there are over 30 different QTLs that may modify, or genetic modifiers that may have a role in the development of EIE. And as you can see in chromosome 2, chromosome 11, and chromosome 16, there are QTLs in there, and the same locations that we picked up in our hippocampus QTLs for myelin basic protein. So this is just to say that the data that you actually get from this computational biology program actually can have biological validation in experimental data. And we've actually done this for the gene in our lab that we're looking at, SIM4-3F, which is actually overexpressed in multiple sclerosis active plaques. We've done that for our particular gene, and it's really yielded some biologically relevant signaling pathways that have been very powerful in terms of looking at the biology of this. So the other thing that you can do is you can map myelin basic protein, which you can see in these circles as MBP. You can actually relate that to all these other blue circles, and all these other blue circles are different genes. And I'm just putting it up just for illustration to show you that there are transcripts or genes that are co-regulated with myelin basic protein, and so you get kind of a network that actually may be biologically relevant. And I won't go around and talk about all these different genes because it's about time for me to finish up. But nonetheless, it's suffice it to say that there's some very biologically relevant genes in this gene network for myelin basic protein that might have some roles in EIE. So to summarize the genomic data, this is a powerful new technique that by comparison of potential gene regulatory pathways, you can look at the controlling the myelin basic protein expression in relation to EIE, or the known EIE data that's in mice that have been developed through other independent validation methods. It's important to keep in mind that this particular technique has its limitations, and I won't go into all of them, one of which is that myelin basic protein is a neurodevelopmental gene that can be modified by compensatory biological responses. But the thing that I wanted people to take away from this technique is this is a way that scientists are going to be able to look at your genome actually on a chip to be able to say, okay, is there something that this particular person has that may predispose them to the pathophysiologic pathway that eventually led to them developing TM or some other autoimmune disease. And so I'm just concluding by saying that we think that the data that we're going to derive from these mirroring models using this computational biology technique may identify genetic modifiers that may be important in human disease, such as pediatric TM. Thank you. Like that are autosomal dominant in character, and they have an inheritance, but it can mimic CIDP. But CIDP itself, I don't think it's known whether there's an inheritance component to it or not. There very well may be, but for instance, I've seen a mother and a daughter have CIDP, okay, in a family. But that data I don't believe is known one way or the other. I was just talking about it as a mimicker.